Well, remember we have our neural tube development in utero, and when does that begin? Yeah, so it very, very early, and a lot of times we've already, the way the neural tube develops, it starts out as like a flat sheet, and then it wraps around and becomes a tube, like a straw-like tube, and it zips all the way from the middle, it zips up and down so that it is completely whole, and that's what should happen. And so that does happen usually by the 4th week of development in pregnancy, and sometimes, especially if it's not a planned pregnancy, mom might not even know she's carrying a baby yet. So that, again, that's very, very early. So there are times when things maybe disrupt that process, and we'll talk about some of those. You'll already talk about some of those in musculoskeletal when you look at like meningoceles and myelomeningoceles. So actually, our literal, when we're born, our brain is very, very vascular, which it always is. It needs a lot of blood flow and oxygen to function and support the rest of our body. But when we're small, as a newborn infant and a young infant, those vessels are very, very much smaller to fit in there, if that makes sense. And that also means they're very friable. And that word means they can easily burst or leak blood. So we'll talk about when that comes into play. Y'all already know that we're born with soft spots on our skull that aren't fully formed yet. What do they do? What do our fontanelles allow for? Yeah, growth, brain growth. Because that first year of life is actually the biggest area of development for actual mass of brain, not necessarily function of brain. So when do we expect our posterior fontanelle to close? 6 to 8. So roughly 6 to 8 weeks, somewhere in there. And what about our anterior fontanelle?
About a year.
About 12 to 18 months. Now that anterior fontanelle is typically getting smaller during that time. It's not like it goes from, a $50 size to nothing overnight. But we do have those considerations that are different on a skull in a young child than they would be in an older adolescent or even an adult. And also, when we have a newborn or very young baby, they have a very mobile cervical spine. So which part of your spine is your cervical spine? Your neck. And so that's why we always have to support the baby's heads, because in relation to the rest of their body, a baby's head is very big, right? It plows the way through the vaginal canal when we are getting birth. And also, again, we're born with a very big brain, and then we make up even more growth in that first year. But that means that those little bitty neck muscles are not able to fully support that head and neck on those young babies. So what do you think that might maybe put us at risk for? Cervical injury, yes. And then also, if we'll talk about shaken baby in a little bit. So you can see how if you can't support your own head and neck and someone were doing that you have a lot more movement of that area as well, which lends to the injury that babies experience in shaken baby syndrome. Obviously, when we're born, we have a formed nervous system, hopefully. But it matures quite a bit over our first couple of years of life. And so how do we see our brain maturing in that first year of life? Do y'all remember the patterns of growth that we experience? Like, we develop control in what ways? Yes, cephalocaudal, and then also proximodistal. So that means we start with head control first, and then we start gaining more middle of the body control down to our legs and toes last. And then we're going to begin able to control things from the core first before we're able to control things out to the distance, like our fine motor. And so we see that when we're looking at all the milestones that we measure in infants and toddlers, right? Like, when do they start laying on their belly and lifting their heads, and then rolling from back to forward and forward to back? When do they push to sit? When do we go from having a regular just a fist grasp to more of a fine pincer grasp where we can pick up cereals or smaller things? And those all exhibit that appropriate growth and development. But you can tell if you look from a newborn up to a 2-year-old how much change you've experienced in the development and maturity of our neurosystem. Part of that also goes with the myelinization of the nerves. We touched on this in health assessment. Do y'all remember this at all? it's been a minute. So when we're first born, what does a myelin sheath do for our nerves? Do y'all know? Yeah, it helps to conduct those nerve impulses quickly and smoothly. When we're first born, we don't have complete myelin sheaths that go from our central nervous system all the way out to the periphery and back. And so those signals are going from the brain out to the ends and then coming back. But it's a slower, longer process because they're on a dirt road and we're going to work up to a nice smooth freeway. Not like an Arkansas freeway but pick a state that has really good roads. That's what the myelin sheath does. It allows for really smooth and fast transport of those nerve impulses out and back. And so we are still developing those myelin sheaths when we're born and through those first couple of years. And that's why, again, another component of why can't we really potty train until we're later toddlerhood? Well, really, we aren't finished with our myelinization till between 2 and 3. So those nerve impulses that go all the way down to our bladder or to our anal sphincter and say, hey, I'm getting kind of full, need to head to the potty, and then send in that message back up to the brain, those are still too slow for us to act on and control early on because the sheaths aren't complete. So once we do get those complete, again, those messages go and come much more quickly and we can act on things. And then head proportion and growth. I have a nice little graphic I'll show you. Here's just a picture of myelin sheaths and how those lead from like our nervous cells all the way out to the periphery and back. But here's a picture of head proportion and growth. So you can see as a newborn, here, this third one in, the head is quite large in proportion to the body, and that's normal. And then it's kind of like saying, have you ever heard like you'll grow into your feet or something like that? Well, we also grow into our head. So our head, although it grows with us, but our body begins to grow faster in proportion to our head, so that we end up as an adolescent and an adult with more of this proportion. But you can see that's very different in relation to the rest of our body. So again, that while that's normal to account for our largest time of brain growth early in childhood, if you are top heavy and have this big old head sitting on top of you when you're trying to learn how to walk, what do you think that might predispose you to? Fall. Yeah, I mean kids fall, they sure do when they're learning to walk, but guess what? That means they fall head first and face first into things, and that's just gravity helping us out there. The nice thing about that is, especially our occipital, that was my funny our occipital and our frontal bones are some of the hardest bones in our body. And so when we fall back or fall forward and hit that, our brain is actually very well protected. And it has to, because it's our chief operating officer. Hey. That one, you know how it, like, when you hit it just wrong and it sends like the weird little nerve twitches all? Yeah, those myelin sheaths are working today, my friend. Perfect. That was a good one. Okay, y'all were already asked to review these on your pre-lecture assignment. So the common laboratory diagnostics and tests, they don't change between adult and children. We use the same sorts of imaging and lab work and things like that. So if you need to just remind yourself the difference between like an ultrasound versus a CT versus an MRI or something like that, those are things you've already talked about, so we're not going to go over them again. I'm going to pick out a few things just to check in with you about. So a lumbar puncture, has anyone been able to see a lumbar puncture performed in clinical, a couple? Okay, so what are our big things? Like, why do we perform a lumbar puncture?
That's the spinal.
Yeah, so we need to take out some of the cerebrospinal fluid. Hereafter, I will just refer to it as CSF. To test it, typically to culture it, right, to make sure there's nothing growing in it. We can also test to see if there's too many proteins or sugars or, things, blood, things like that in there. What do we know about actually when we're doing the procedure? What's the role of the nurse? To hold and help stabilize, right? Because we don't want them flopping around with a needle in their back. That sounds like a terrible idea. What else is the role of the nurse? Yeah, monitor vital signs, especially, sometimes heart rates might be getting high. If it's a floppy baby with not great head control and we've collapsed our airway, Could their stats start dropping? Yes, because do we do these in the NICU? Yes. What else? Is this a clean procedure? Is it sterile? Okay, so what do we need to be very careful of? Yeah, so helping to maintain the sterile fields, and that goes along with positioning and helping, maybe we're handing things or moving things. So we're collecting a lab, right? What's your role when those vials get handed off to you? So you gotta make sure it's labeled appropriately, it has the correct requisition form or whatever the procedure for where you're working is, and that it gets to the lab in a timely manner. It can't just sit on the, bedside table all day and sit in the sun or whatever. Whatever you might do with it besides putting it to the lab, that's not good. What about consent? We can witness that consent. Yes, we can. Can you obtain consent?
No.
Why not?
That's the doctor.
That is the doctor, but let's be inclusive here, that is the provider, because nurse practitioners can perform lumbar punctures, right? PAs can perform lumbar punctures, so if it's within their scope of practice and they're going to be the one performing that, they are the ones that should be obtaining consent. As the bedside RN, now someday, some of y'all will probably go into being the ones that obtain consent. Good for you, you should do that. But currently, right now, what y'all are gonna be graduating and doing is witnessing. Do you do the initial education on it?
No.
Like the parents and family? No. The person who is obtaining consent needs to be the one making sure they understand what they're consenting for. So you have to know your scope of practice, because once you get this license, you work really hard for it, you want to keep it, right? But can you clarify questions and answers, like if they're like, okay, I know they said this, what does that mean? Can you answer that? Absolutely, that's going to be part of your job. Okay, so we go in between the L3 and the L4, which is our lower back here, and that can be very hard, especially for a kid if we haven't calmed them, pharmacologically. Sometimes you might need extra hands to hold, depending on the size and the reactivity of the kid. Because again, once we get this sterile site done, we want to get a nice clean sample. We call that a champagne tap. If there's a lot of trauma where we have to stick multiple times, there's going to be blood in it, and that can contaminate our sample. So we'd like to just go in once, get a sample of the CSF, and go back out. And so that means if we need a sister or brother nurse to help us hold and position and make sure it's safe and appropriate, that we do that. Okay, so here's what we expect nice cerebrospinal fluid to look like, either a light yellow to clear. There really shouldn't be anything else in it. Do you notice this one looks very cloudy? What might make cloudy CSF? Infection, white blood cells, even potentially actual pus, yes. So we want it to be nice and clear. This is just a quick example of an image that we would be able to see using a head ultrasound. We use these a lot in kids who have not had their fontanelles closed all the way, and we're trying to see, it's not super clear, like we can't see all the sulci and stuff of the brain, but we can see the main structures. And so we do have ventricles in the brain, which are the dark parts here, and that's where we actually create and then recycle our cerebrospinal fluid. So they're hollow in the way that it's not brain tissue there, but it's full of fluid, which that's why it looks dark. So we actually have a couple, but from the top, this is what we can see, except for there should be another one right here. And so that is showing us bleeding actually in there. So this is just an example. Head ultrasounds, have y'all seen those performed? We do them a lot in the NICU. So those are super easy because they're non-invasive. We can come to the bedside and do them, and they take about 5 minutes, especially if the baby is quiet. So that is imaging that we would really like to start with for a lot of our things, because we don't have to like strap them down, hold them still for an hour, or anything like that. So this is something that you might see. This one is a CT, and you can see that it is definitely more defined, but it's still kind of grainy. And what you see here is, see the little like encapsulated circles? Those are actually, I don't know, they could be infection or they could be cancerous growths here. And you can see like this one has a midline shift. You see the midline of the brain and it's shifted to the side. So we can actually see a lot with a CT. What are the upsides of a CT? Like how long does it take?
It's quick.
It's pretty quick. It is a lot faster than an MRI. You still have to be still. The machine is still big. It's like a big donut, and it does whir and kind of make some sounds. So you do need to prep your kiddo if they're old enough to be concerned about that. Again, they have to be still. So if it's like an infant or a toddler, we might need to bundle or help kind of restrain them in a comfortable, calming way. Sometimes, again, this is usually done within a matter of minutes. So we really try not to give any pharmacological. But we might have to have like an anxiolytic on board if they're really fearful. And then here's what we would get with an MRI. So the way the MRI works is it actually is scanning through several layers of whatever we're imaging, and then it compiles those layers together, so you get a really lovely, clear, crisp image. I mean, that is detailed, right? But they take forever. So plan on it taking an hour. And you just try to get, especially a small child, to hold very, very still for an hour. And you can imagine how it would be very challenging. So things you want to do with an infant especially is make sure, if appropriate, if their orders are appropriate, if they're fed beforehand, they're changed beforehand, they're bundled nicely, we have their pacifier, like all the things that would make a baby happy and quiet and sleepy so that they can just sleep through it. A lot of our pediatric MRIs do have things where they can listen to music. Sometimes we even have ways that we can like project an image or show a little video. They can take a Lovey in there with them as long as obviously there's no metal, because remember, it's a huge magnet and the magnet's always on. But these give us the best images. Obviously they're very expensive, they take a lot of time, but depending on what we need, like we would typically start out with an ultrasound if we could, then we go to a CT, and if we still need more detail, then we would work up to an MRI. We don't normally go straight to an MRI first unless it's something pretty dramatic. But again, you can see here, like you can see our ventricles very clearly. This one, you can see that white part could be ischemia from either lack of blood flow or lack of oxygen, or, anyhow. They're very nice images, but it's an investment of time and money. What is this one? It's on there, but. So have any of you been able to see an EEG performed while you were in clinical? Okay, how many sensors and electrodes are on the head? Like 112. No, I don't know how many exactly, but y'all know the tech comes in and applies them, and they have this like pasty glue. They all have to be on there for them to read appropriately. And they feel weird because it pulls, once the glue dries, that kind of pulls on your skin. Sometimes it can be hard to work around the hair that is there as well. So it gives us a tracing of the brain activity, and what we really like to do is video monitoring with our EEGs. So we'll do a 24-hour, and they'll be on the EEG monitor, but also we have the video capacity. So if we start seeing something occur in the brain waves, then we can match that up with what was happening on the video at that time and see what the outside appearance is. And we'll talk about when we get to epilepsy why that matters. How do y'all think that this might affect our pediatric clients?
They try to pull it off.
Yeah, I mean, kids sometimes are not super conscientious. Like adults typically like really guard their ID. If there's a line on them, they're like, I don't want to move. Kids are like, ah! They don't care. Also, if any of you are the proud owners of children, you'll know they'll be like, I don't like this. This pulls, it feels weird. It's itchy. And so that is a thing. Sometimes keeping these on them for a solid 24 hours can be a little challenging. But it does give us really good information if we're trying to see like what's actually going on with the electrical activity of the brain. Okay, so those are the ones I wanted to make sure that y'all really do include or know about, because you will see we use all of those a lot. Okay, so when we're assessing the neuro system as part of your lecture prep assignment, I wanted y'all to think about what a normal neuro exam would look like, and how that might also be a little different between infants and then not infants, because we know y'all do the cranial nerve assessments between age groups all semester, and you know that infants can't do some things, whereas older kids can. So our level of consciousness, that has gradients to it, and we'll talk about that in a second. But that's typically one of the very first and earliest changes that we see if we have a problem in our intracranial pressure. So we're gonna talk about that in a second. So changes in level of consciousness, but they can be very subtle. So also, again, any of you who've been around kids, you know, if they run and play all day, sometimes they can be real lethargic and hard to wake up and hard to keep awake. And I mean, if that were an adult on a regular day, you'd be like, oh my goodness, are you okay? And a kid, they're just like, yeah, we've been at the park and we had a birthday party and, you know, they're coming down off their cake high or whatever. Vital signs, now remember, y'all have to be able to delineate those per age group, which y'all have been working with that all semester too. So head, face, and neck. Remember, we've already gone through the fontanelles, so that's a change in the infant group. And the way we assess our cranial nerves, like, can infants do the accommodation in Perlin? I mean, we can't have them follow the directions. So can they do it? I mean, eventually, yes, but they can't do it on command reliably. Same thing with toddlers. So just remembering those normal things that we expect versus what would be an abnormal change. That's kind of what I want y'all to think about here. So motor function and reflexes, obviously, y'all remember all the infant reflexes that Ms. Palmer did with y'all? And how they all have a time to be there and then to disappear. So just remembering if it's an appropriate reflex, but what age is the child, right? Because if I have a continuing Babinski reflex and now I'm 14, that ain't right. You're not supposed to still have that. So reflexes, some reflexes come and go. Now our deep tendon reflexes, those are a little bit different and tend to be more, you know, consistent throughout our lifespan. But also like motor function and sensory function, you know, and adults, we like to say like their gait is stable and steady. They have equal strength and range of motion from one side of the body to the other. But if we're an infant, we don't have a gait yet. We're not walking. So how do you measure motor function then? So, yeah. So, well, that posturing would be a not cool thing. But yes, that would definitely be something to look at and note. But there are other things like when you are just playing with a baby and you can assess like if you're moving their legs, do they push back on you and does it feel equal? And you know, that sort of thing is something that you can document as well because again, they're not going to have a smooth and steady gait. Sensory function, again, while older kids can tell you, yes, I feel you tickling my toes, you know, little kids or infants can't, but again, when they have a Babinski, they couldn't feel your finger go up their foot, right? So that actually tells you they have sensory function in their foot because that's how that works. Same thing, like we do the cotton balls on the cheeks to see if they have sensory function, but if they're an infant and they have a root reflex, that means they have that sensory function because they wouldn't root if they didn't feel the brush on their cheek. So those kind of little bridges that you can build to still make sure that you know that that baby is doing the things that you would see in an older child, but we just have to make accommodations for that. Okay, and increased intracranial pressure, we're going to talk about in just a second. We'll just kind of put a pin in that for a second. Okay, I have a few little things on what they see above them, and then you can gently move their head so that their eyes move through the cardinal phases and everything. So that's just a reminder. Again, we talked about that in health assessment, that it's been a hot minute. There you go. Thank you. What do we think about this? What should our pupils be doing?
Constrained.
Reacting. And you remember when we did like your prep for clinical and you can measure the pupil size on your pen light, remember that? And they really should be equal on both sides and whether they're dilated or whether they retract down with the light, they should also react equally on both sides. So if we are fixed and dilated here, is that a good thing? No. This is a very not good thing. Now, sometimes we will have very dilated eyes with opioid use, whether we gave that to them or they took that on their own, but they are not fixed. They will still have some reaction. That's not good. That's not good for that patient. I told my husband this morning, I'm like, it's the last one, I can do it. I don't know if y'all know this, but this is tiring for us too. What do we call this? Nystagmus. So one thing when we see nystagmus in an unusual circumstance, like what do we, especially far side nystagmus, what do we use that for? Well, maybe none of you have been pulled over for sobriety, so it would be good. But if we have them trapped to the far side and they have substantial nystagmus, that can be an indicator. It shouldn't be a standalone indicator, but it can be an indicator that they're inebriated. But some people, like this kid right here, just have nystagmus. Like this is just his. Have any of you ever seen someone who has nystagmus like all the time? Okay. Yeah. Oh really? So what do you think that does to the image that their eyes make for their brain? So fascinatingly enough, they don't see a blurry image. They don't see movement. Their eyes and brain, the brain takes out the movement and then makes them a regular image.
So I was experiencing a lot of vertigo, and they sent me to a PT, and they did that whole, like, I don't know what it's called, but they like move my neck around, and it's for the crystals in the ear.
Crystals. So anyhow, that just goes to show you the power of the brain, that it can actually filter out that information and create a still image for the people who have nystagmus. Now, obviously, that is still an abnormal, and we want to chart that. Is that what you're going to ask? Yeah, we need to make a note of that. Now, if that is just the only thing wrong, and we don't really do anything about it, but. Okay, so levels of consciousness. I told y'all this occurs on a gradient, and I think that you've probably heard these before. You know, full consciousness is we're up and around and talking and interacting and doing all the things that we would expect as appropriate per age group. So it's not fair, you know, for adults, y'all like to put 8 and a times 3. Obviously, you can't put that for a young child because they might be alert and you might say, where are you? And they're like, Mars or Bluey's house, or, I mean, obviously if an adult answered you like that, that would be very concerning. When a 3-year-old answers you like that, you're like, that's adorable. So do just remember, you have to kind of take that into consideration, what's appropriate for that age group. So confusion, kind of the next step down. We want full consciousness. So confusion, what would that be? This look that y'all are giving me right now. So, that would be like we're still responsive and interacting, but maybe we legitimately are not making full sense, and in a way that even parents might be like, not like an I don't know, my kid's weird, like I can, you know, if any of you have a weird kid, you'll know they'll sometimes, like my youngest, you never can't tell what's going to come out of his mouth, but that's just him all the time. But there's a time when the parents or caregivers will be like, this is weird, and that's when we might have dipped down into confusion. Obtunded, so that's when we are less in touch with reality for sure. We might be sleepy but able to be awoken by normal kind of stimuli, but kind of like drifting off and really not super interactive with the environment or the people in the environment. Then we get to stupor. That's when like we can't keep those people awake unless we are doing things to like, hey, no really, hey, wake up, come on, stay with me here, stay with me. That sort of thing consistently. And then obviously coma, we're not reactive or waking up even to painful stimuli. So that would be the kid that, you know, we're laying there and we're like, we gotta get some lab stat, we need to start an IV, and there's not reaction to starting an IV or to sticking for lab or things like that. So do just know it is a gradient. So why does that matter? I mean, it matters for our assessment because obviously the further down we get on this list, the worse it is, whatever is going on. But also, we use this kind of for our coma scales. Y'all have worked with the Glasgow Coma Scale already, yes? And it works great with adults. But we have a pediatric Glasgow Coma Scale that we use for our younger kids because they can't always do the things on the regular Glasgow Coma Scale. So some differences. You will see we have less than a year on the eye opening and motor response and then over a year. And so those those are still graded. You can see, like, do we spontaneously open our eyes to a shout or a loud noise, to pain? Do we motor response, are we just moving around normally? Are we only localizing, like, we're not really moving around, but then we get that ID stick and we jerk our arms sort of a thing, that would be localizing pain. And then we have flexion, withdrawal, and then you see that we get down into the corticate and decerebrate rigidity. So those are our posturing, right? And y'all talk about that, we're gonna look at it again in a second. And you can see how that's a little bit different over here for over a year. And then our verbal response is different, because obviously a very young child can't tell me their name or where they are. So do they smile or coo appropriately? Are they crying but they're consolable? Which would also still be okay, kids cry, but we expect that we can, especially caregiver can help with that. Persistent, inappropriate crying and or screaming, grunts, agitated, restless, or no response. So you can see that's very different from our regular scale. And then appropriate words and phrases when they get a little older and would know some words. And then over 5, we have disoriented or confused. So that's where you kind of need to know the level. So caregiver help on that assessment can be very helpful for these younger kids that you still might be like, I mean, they answered me, that didn't make any sense. Is it the words I'm using, or is it actually, it's a weird kid that you can't ever tell what they're gonna say, or is this really a concerning thing? So, posturing, decorticate, remember those arms pull into the core. Posturing is not a relaxed position. Posturing, like the muscles are engaged. It is hard to move a client out of the posture if they are posturing. Like you can be pulling on those arms looking for an IV site or something and that's gonna be rough. So they don't just lay them here on their chest either like a vampire or something. They're actually kind of pronated in, typically like the backs of that hands would even touch. And again, it's a rigid posture. And the legs are extended, the toes pointed down. And then we have the decerebrate, and that's when we've gone the opposite way. So the arms extend and pronate, so they, again, the backs of the hands lay against the body instead of how you normally would, but the legs still look very similar. So here we have our decerebrate posturing, and you can see this lady even has like the head turned to the side. That does happen sometimes. This one is one y'all might not know. Have y'all seen this one before? Yes. Yeah, so, and also sometimes we see it in meningitis. So this is called epistotonic posturing, and it looks like a fish out of water, like they arch backwards, and it can bring them up off of the bed. It's very uncomfortable, it's very serious if we're doing epistotonic posturing. You know what, actually, let me walk that one back. No posturing is good. We don't want to see posturing, but epistotonic posturing is very bad. So we have another decerebrate posturing here, and you can see like this guy's hands are even up off of the mattress, like the tips of the fingers are touching, but the arms are not lying on the mattress. And I really couldn't find a good decorticate, so and I'll just know, pulled into the cord. Okay, so when you're thinking about our nervous system, our brain and our spinal cord, and what are they encased in? Skull and spine, our vertebra, right? And all of that is bone. So we have our brain and our spinal cord, we have little nerves in there, and all of that, we're floating in cerebrospinal fluid and then encased in bone. And so especially past that first year to 18 months of life, when our skull is still fusing, but after that, like there's not room for anything else in that system. We have a very hard and fast wall, a fortress basically, that is keeping all of that in there. So anytime we have increasing pressure, even if it is just a little bit, we will see effects. Why would we maybe have increasing pressure? Hemorrhage, so we have extra blood in our fortress. What else? Tumor, so we have extra mass in our fortress. What else? Injury, so what does injury cause? How does your body react to injury? Swelling, we send more blood up there and all the things, so swelling, and then we have makes more mass in our fortress. Infection can also cause swelling, right? It could also cause drainage, like purulent drainage, like pus. So all of those things can contribute to increasing our intracranial pressure. And again, it doesn't take much because there's just not a lot of extra room besides what growth happens very gradually. These sorts of things tend to happen more acutely, and so we would see that change in pressure happen over time, right? So things like the early signs and symptoms of increasing ICP or intracranial pressure, we obviously want to be able to intervene and act while it's early, because the longer we're applying extra pressure, the more likely we are to have more severe consequences of that. So we have things like headache, that makes sense. But how might a young child tell you they have a headache? What might you see in an infant or a toddler whose head is hurting? So maybe a younger child might hold their head, an infant probably wouldn't, but that might be a thing. What else? Irritability, yeah. So being fussy, that part about inconsolable, like not being able to console with the normal routes. Again, some of that is investigative work on our part, but that's what you have to do when you have a nonverbal client that isn't able to communicate with you. Vomiting is a possibility. Now, do babies vomit? Yeah, they spit up. This is not the normal little, like, I ate an ounce too much or Thanksgiving meal for a baby. This is vomit, and it can frequently be very forceful. I mean, I don't know if any of you watched The Exorcist for Halloween, but if you, like, away from the body with force. Blurred vision or diplopia, or double vision. So, again, how would a young child maybe describe that or complain about that?
Could it be falls or hard down?
Maybe falls or running into things. Yeah, maybe they're not seeing clearly. That might be a thing. What else? Maybe rubbing their eyes or being like, it looks funny. You know, that it's hard to be like, Mother, I have diplopia. No, I mean, it's not going to happen. I'm experiencing blurry vision. Maybe if they're raised on all the pharmaceutical commercials out there with the adverse effects. And also, like, what about dizziness? That could be holding their hands, but it could be changes in balance, and if they have gait, changes in gait. Also, what does dizziness lead to? Ashley told us about the vertigo. What did you feel when you had vertigo?
Probably don't really pass out. Like,
Yeah, just kind of like lightheaded. Sometimes it'll make you nauseous, which can lead to the vomiting. Now, things like decreased pulse and respirations, increased pulse pressure and blood pressure, unequal reactionary time in your pupils, those we can measure. We can actually put a number to those. So that's easier for us to assess. So some of these other ones are like soft skill assessments, and then we have our hard skill assessments. What are sunset eyes? So that's when we actually have enough intracranial pressure to press on our ocular area, and it deviates your eyeball downward. So then you can see the white sclera of your eye. It looks like you're surprised, but they're not. Their eyes are not open wider. It's actually deviating the eyeball down so you can see the white. We'll look at it in a second. We have that changes in level of consciousness and irritability. Seizure activity obviously could be an issue. And in infants, since we have those soft spots in the skull, we can actually feel those. If they are bulging or tense, and they will be bulging or tense if they are crying and screaming their head off. If they are straining really hard with the bowel movement. Those are things that short term do increase your intracranial pressure, but then they go away, right? But if that is consistent, then that would be an indicator for us. If it is there for a long time and before our cranial sutures seal, then it can actually begin to split that cranial suture line, so you can actually feel a gap there. Dilated scalp veins is another, I'll show you a picture. And then there is a high-pitched neurocry that our neuro babies will have, and it is so hard to explain, but if any of you have had babies, you know that, or been around babies, there are different cries for different things. So I'm mildly uncomfortable, I'm kind of hungry, I'm bored and I want attention, I'm tired, leave me alone, and then the I'm in pain cry. And the I'm in pain cry tends to be much more sharp and shrill. It is more like that, but that is their always cry. It can be really hard to care for a neuro baby that cries a lot, because it's just one of those things where you're like, oh my gosh, it like goes straight to the cortex of your brain. You're just like, oh. So here's a picture of some bulging fontanelles. So you can see, this is a little thingy baby, but do you see that big bulge right here? And actually this comes down, it split our cranial suture line, so this comes down some into the forehead. This one is an older baby, and that's a smaller bulge, but it is still there. Here's a picture of those dilated scalp things. Those are not where you would want to place an IV. When we place an IV, we want medicines and fluids to run smoothly. Why are those vessels dilated? Pressure, yeah, there's so much pressure it's not able to flow back out well. So that would not be an ideal place to try to put more fluid or meds. You can also see this baby has hydrocephalus. Can you see how large the forehead is, and it's kind of made more of a rounded at the top and pointed at the bottom head. So we'll talk about that a little later in the lecture. Here's some examples of sunset eyes where you can clearly see the white where it shouldn't be. We don't typically see that much white between the iris and the upper lid. Again, they look surprised. It's kind of cute when you first see it, but then you're like, oh, well, that's sad why they have it, right? Okay, so late signs and symptoms of increasing intracranial pressure. These are obviously more serious. So, when I say the first one, we had a change in level of consciousness. So that might be, instead of a full consciousness, we maybe are operating on the confusion level. But when we get to the late area here, we're talking more about like a stupor or a coma. Like we are having a really hard time keeping them awake and interacting with us. Like it has to be consistently like, hey, 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 shaking, patting, those sorts of things, or we really can't get them to respond to us at all. So this is the very low level of consciousness that we're looking at here. Decreased motor and sensory responses, again, that goes with our Glasgow Coma scale. Like, do we stick them and they don't even pull back from pain, or do they only localize pain? It's, that sort of component. Because if they're that lower level consciousness, they're really probably not following any verbal commands at all to perform a motor response for us. We might see bradycardia and irregular respirations, and that doesn't mean we're down by like a point or two on what we would expect for the age group. That means like we're significantly low on our bradycardia, or on our heart rate. Sorry, I was pulling up this video. And then the irregular respirations, one that we do typically see other places unless we might be in hospice care, is the Cheyne Stokes or the Cheney Stokes respirations. And so what this is we'll have long periods of apnea, and then we kind of have short panting breaths that crescendo into big gasping breaths, and then they crescendo again and littler until we go apneic again. And that pattern happens over and over again. For all those musical people out there, I threw in some musical terms for you. You can see like we're significantly gasping, and it starts to taper off and trail off. Obviously this is not a pediatric client, but this is a good video. So you can see we're getting like longer in between respirations. They're getting less and less movement wise. And then here in a minute, she'll peter back off and have another longer time of apnea where we don't see any respiratory activity at all. That's the kind of thing that you have to set your alarms for specifically, or they will have them going off all day long. If we see posturing, that would be a late sign of our increasing intracranial pressure. Or if we get to that fixed and dilated pupils, that can be, not always, but it can be an indicator of brain death. Or stem herniation at the back of the neck. So that would be bad. We don't want to get there. We want to have been able to intervene and make things better before we get to the fixed and dilated pupils. Okay, so let's go ahead and take a quick break here. Different things, fever, which we'll talk about, infection, trauma, like if you fall and hit your head hard enough, sometimes we'll see people have like some seizure activity after that. Hypoxia, but what I want to get to is the bottom of the list here really is epilepsy. So what if we just actually have seizures as a disorder in themselves? So when we are talking about epilepsy, we're talking about seizures that are triggered recurrently in the brain. That's not just so you can't have a seizure one time and then you have epilepsy. That's not what it is. But when we're talking about seizures, that is disordered electrical impulses in the brain. So we know that from the EEG, like wherever we place the leads, we have an expected tracing, kind of like you would for your heart or your respiratory rate or something like that if we had you on a monitor. So when that gets disordered, and it can become disordered in either a central localized area, or it can spread all across the brain. There are different kinds of seizures we'll talk about. And that happens over and over again. That's when we're looking at epilepsy. Now these have to be 2 or more seizures that are more than 24 hours apart and that are unprovoked. So what does unprovoked mean? Yes, they just happened, nothing triggered it, there was no infection, there was no trauma, there was no crazy electrolytes going on, or super low blood sugars, or anything like that. It's just, normal of the day, and we had a seizure. The good thing about epilepsy is actually it has a very good prognosis. A fair few kids diagnosed with pediatric epilepsy actually grow out of it as they get older. And so that's interesting. Why does that happen? We don't actually fully know that process. But that is a good thing. The other thing is, and a lot of our clients, if we do the right things, their epilepsy can be very well controlled. And while they have to do the right things, actually the seizure component of it will have a small impact, only a small impact on their life, whereas it could be a lot worse. So there are, again, I don't want you, like your book and ATI both actually break this down by very specific categories. You do not have to know all of that. Just generally, when we say something is partial, that's typically one area of the brain is involved, whereas generalized means we have the entire brain involved. What do you think, just off of that description, how do you think that might look outside? Do you think generalized might be more, yeah, so they typically are more pronounced in their symptoms. So I do just want to show you some little bitty short clips. I should have already had these brought up. That's what I should have been doing in the break instead of talking. But here I was talking. Okay, so here is one version, and this is an adorable little baby. And we're gonna just watch for a second. Okay, do you see this movement of this arm that keeps happening? This is an infantile spasm, and it is actually a version of seizure activity. Obviously, that's really pretty mild, and babies kick and flop all the time anyhow, so that would be maybe kind of hard to pick up on initially, right? You can see how that would be difficult. This one, hold on. This one is what most people think about when they think of a seizure. This would be more of a tonic-clonic seizure. These used to be called grand mal seizures. They were initially all named in French. Y'all can imagine that didn't persist here very long. Actually, it did for a couple hundred years, but anyhow. So that's what most people think about when they think about a seizure, or how we see seizures depicted like in movies or cinema, right? And those are more generalized, meaning there's much more of the brain involved. Those are the kind of seizures where we might see the child lose bowel or bladder control and have like a long post-school period where they have to recover. Now this one is an interesting kind of seizure. I'm going to fast forward because it starts around here. So he's hyperventilating. That's what he's doing. By blowing on this tissue and moving it, he's making himself hyperventilate. And you see, he just kind of has a little gap there where he just blinks and kind of spaces out, and then he goes right back to doing what he was doing. He doesn't even realize that there was a difference between the before and after. Do y'all know what those are called? Absent seizures, or you'll hear them say absence, because again, they were all named in French first. And so this is something that we'll see a lot of times. The teachers start noticing that, like the child is daydreaming or spacing out, not paying attention. But what's the difference between daydreaming and having an absent seizure?
You can.
Yes, can you bring them back? Yeah, if I walked up in front of you and you were daydreaming and I'm like, Hannah, come on, pay attention. I'm kidding, she's taking notes, she's paying attention. But if I did that and you were daydreaming, you'd be like, oh, hold her up, this way. But if you were having an absent seizure, nothing. There wouldn't be, you wouldn't even process that stimuli. So that is a difference. Now imagine doing that a couple hundred times a day. Do you think that might interfere with your learning? Definitely. So these can happen. They're usually very short, maybe just a couple of seconds. Sometimes even if that. But there's that gap there. They don't remember what happened while that was occurring. So if that's happened a couple hundred times a day during their school day, you know, a lot of times we do see, like, their grades are suffering, their parents are wanting to test them for, like, you know, ADD or things like that, and really we find out they're experiencing absence seizures. But again, that's a very different look from what cinema typically portrays seizure activity as. This one is interesting. Pull it over quick. Okay. This little dude's on the plate. We're looking at the little guy in the blue shirt and the vest. Notice that little, and it happens at the very, very beginning. The guy's trying to pull it over. See that? So those are called atonic seizures, and they're brief, but it's where they actually lose their muscle control for just a few seconds. So what do you think that might lead to problems with? Falls, injury, yes, that is a safety concern. Obviously his parent is right there, and he's, you know, still being a kid. But it's just very brief. It usually only lasts for like maybe 2 or 3 seconds, but there's like their whole body, sometimes you'll see don't actually like fall over or go down to the ground. He was kind of already sitting and leaning on that stair. Yes, go ahead. So absence seizures, that's interesting. They don't lose the muscle control. It's more like they just take a little cognitive break for a little cognitive vacation for a few seconds. They don't typically like droop their head or fall out of their seat or anything like that. Because it's affecting a different area of the brain. That's a good question. So these kids are actually aware of it, and sometimes they'll even know that it's coming and they'll sit. And then they'll, especially if they're a little older, but then they just have that moment where they just lose the muscle control part, but they're aware of it. So it's kind of like they flip-flop. Yeah. Okay, the last little stuff I want to show you real quick. Is this lovely salad. This baby, we are having a seizure here, but again, this looks different from a lot of seizure activity too. But do you see, this is almost like a posturing. Do you see that like rigid, we're holding the arm off the floor, the feet are off the floor, and a lot of times we're getting a little dusky looking because we're holding our breath during these as well. So we would fully expect during one of these for their sats to drop, and then of course once the seizure activity is over, then they need a recovery position, and they'll flip over and start breathing again. But can you see how we're getting a little pale and dusky looking? So this is another type of seizure activity that you might be able to see. So they look very different depending on which areas of the brain are affected. So that also means sometimes we have to treat them differently. So a lot of times we do use different pharmacological interventions, medications. Y'all have already talked about things like levetiracetam, Keppra, you know, things like that. I'm not going to go back over that sort of pharmacology. But do know there's some takeaways for the meds. And the most important thing with our anti-epileptic medications is they have to be taken at the same time and the same dose every day. Because when we take a medication, we're trying to stay in our therapeutic range, right? Above the level where they work and below the level where they're toxic. So we have this range. If we skip a dose, or we're 2 or 3 hours late on a dose, what are we running the risk of? We're running the risk of dipping out of our range, and then seizure activity will happen. And the longer we've been controlled on medication, if we abruptly stop medication, what do we also run the risk of, which is an emergency? And y'all talked about with Ms. Harkness. Maybe it's a sticker. I don't know. Status epilepticus, y'all, yeah? Where it's just uninterrupted seizure activity, and that can be life-threatening. So we want to make sure we do really good education with the client and family who's starting anti-epileptic meds. That this is not the one where you accidentally run out of your medication, or you go on vacation and leave your meds at home, and you're like, it's only a long weekend, it'll be fine. No, it will not. You're going to get to visit a new ER is what you're going to get to do. Don't do that. Surgery, there are sometimes, especially if they're very young, that we will actually go in and cauterize an area of the brain that's causing the disordered electrical impulses. And that's if they're very focal, very specific to one spot. And the point about it being young is kids' brains are very plastic. So if we cauterize one thing that was in charge of something, like another area of the brain will take over that work. That won't work for everything. It definitely wouldn't work for generalized seizures. But there are some types that we'll see that they originate right here. This is the problem spot. And if we can go and surgically remove that or burn that out, then no more seizure.
So like if they have a change in dose, do they have to stay in the hospital for monitoring, or are they okay to go home?
That's a really good question. So she asked if they have a change in dose on their medication, do they have to like stay in the hospital for monitoring, or do they have to go home? So it would depend. Can I come back to it in another slide, because we're going to talk about that a little bit. Okay, but make sure if I don't answer you the way you want me to, remind me. Okay, so I think we'll cover it. Another way we can control this is the ketogenic diet. So have you all heard of the ketogenic diet before? Because there's a lot of people on the keto diet for weight loss. Did you know that when you force your body to metabolize fats for all of your energy, it affects your brain waves? Because we use it to control seizure activity. I'm not saying it doesn't work for weight loss. I'm just saying you should know your brain might be working a little differently. Maybe do it in consultation with your doctor or provider. So we'll look at the ketogenic diet here in a minute. A lot of times we use the ketogenic diet with pharmacological management, like if we're not getting great control with our meds, but we're kind of topped out on where we need to be for our weight and age, and then we'll add in the ketogenic diet and we have really good control. So that is something. And then there's also a vagal nerve stimulator. It only works with certain types of seizure disorders that originate at the vagal nerve site. But it's almost like a pacemaker for the heart. So it's implanted. It actually is a very similar looking device if you see it outside of the body. And what it does is it monitors the impulses at the vagal nerve site. And if it monitors that they're becoming disordered, kind of like a pacemaker when the heart rate becomes disordered, it will give it a shock to reorder it. So again, we can't use this with every seizure type, and I just want you to know that it is a thing, and that's pretty cool if you can have that implanted to manage your epilepsy. So ketogenic diet, now this one is mostly fats. Usually it sits between somewhere 75 to 80% of your nutrient intake is fat-based. And then you have about 15 to 20% in protein, and then that last little percent is carbs. So, remind me, what kind of things make up our fat group? What foods? Butter, oils, yeah? Avocados. How does a meal make from butter, oil, and avocado? Huh. Guacamole. So what are proteins? What are some examples of proteins? Yeah, meats, fish, cheese. Yeah, poultry counts as meat in my book. And what about carbs? Let's face it, it's all the good things, right? Breads, pastas, crackers, candy, cereals, the things that kids like to eat. So, I'm sure you can imagine, like they can have some things that are lower carbs, and we're going to work with some of this afternoon so that y'all can see how challenging this diet is. But when you look at all the things that they can't eat, potatoes, God made potatoes great. They're great any way you cook them. They can't have them. It's so sad. That would be hard to get a kid to be on that diet, and you can't deviate from the diet. You have to maintain the little acidosis that you're creating there in order for it to work. And it can be very challenging, but on the other hand, it can be very, very effective in our seizure management. It's also, I'm not gonna lie, it's hard for families to implement because, you have one kid that has to eat this and everyone else is like, I don't want that. But then do you eat like the good food in front of that kid? How would you manage? That's a whole, talk about ethics, right, Vanessa? Ethically, would that be okay? Okay, so seeing seizures clinically, like actually in the hospital with us or in the clinic is pretty rare, but everyone has a phone and videos these days, so that's really great. It's actually been very helpful over the last 25 years, that everyone can just be like, this is what happened, see, I got it right here, and you're like, oh yeah, that's super, now I can see. We do need to make sure we ask about the current complaint, any recent changes in medical history especially, and then long-term, if there's been family history, because there seems to be a little bit of a familial link with epilepsy, although we've never traced it to an actual, like it's on the long arm of this, we don't know chromosomally, but there may be a familial link. Some things that sometimes look like epilepsy, especially in our younger kids, like breath holding or apnea or GERD, and babies, when they have that reflux, they tend to stiffen and arch their back and kind of hold their breath, and it can very much look like an infantile spasm or that little partial simple seizure we saw at the end. So there are some things, like if they are coming in with complaints, we're not just gonna be like, epilepsy right there. We're going to have to do our homework, right? So that would involve a thorough neuro exam. We wanna see any evidence that they have of what's happening at home when they're seeing these events. We wanna make sure we're looking at their development, like is their language and their motor skills and their mental status and their behavioral development, is it all appropriate to their age? And if we see a seizure as a nurse, obviously we want to look at the characteristics, but we have certain things we have to document. So specifically, very specifically, obviously the time and the date, what happened right before, what happened after, what you did to keep them safe, what are things that we do to keep our clients safe if they're experiencing a seizure.
We roll on their side.
Yeah, so we want to put them on their side. What are they at risk for? Aspiration, whether it's on spit or maybe if they vomit, because sometimes they will. If we're in the hospital, what would we want to have at our bedside always? Suction. We might want to have some oxygen blow by, because sometimes, again, they'll hold their breath. Although they will recover. They will recover on their own, but sometimes we'll give them a little bit of blow by to help boost their SpO2 after their seizure. But we want to also make sure, like, bed's in the lowest position, they're in a safe place. If they're just flat on the ground, we move things away from them. We try to cushion their head, like maybe if we had a sweatshirt on or something like that. Do we put something in their mouth while they're seizing? No, that's dangerous for them and for you. But we do want to make sure we try to support them in a safe way. So that means like trying to keep their airway clear by like laying them on their side, so if something happens, it can go out and not back down. But we'll work with some of this afternoon too. Things that we do have to make sure we look at to make sure it is epilepsy and not something else. Obviously, if our electrolytes or our glucose levels are really low, or even actually some of them really high, they could cause different tetany or seizure-like activity. That's very possible, so we need to make sure our labs are just normal. If we do have any sort of infectious process, like we've been running a high fever or anything like that, we would probably want to do a lumbar puncture to make sure we don't have an infectious process that's progressed to our neuro system. If there's trauma that might have come before this, a skull x-ray would be good, or a CT, MRI, ultrasound, those sorts of things. If we're considering that maybe it could have been infection, it could be swelling, it could be tumor, any of those if we're concerned. And then we would want to do a video EEG to actually localize, if it is localized, where the seizure is coming from, or if it is more generalized. And then again with that video component, then we can see on the outside what happens to that person, because now we know they look like very different things when we see the disordered electrical activity on the tracing from the EEG. Okay, and here's where I'm going to answer your question here in just a second. So our big goal is to prevent injury. We can't cure epilepsy, we support epilepsy. That means a lot of teaching and education too. So we talked about the medication part, same drug, same dose, same time, every day. We do frequently see with some of these, because they tend to be downers, like some sleepiness effects with it, especially until the child gets used to the dosage of medication. Sometimes they'll have some changes in mood or behavior, especially with levetiracetam or Keppra. So sometimes we do want to warn about that. Sometimes they'll have some visual changes. That's not as common, actually. Now, if we're well controlled with our medication and our therapy, whatever we're doing, for 2 years, that's when we might start talking in concert with our team. So not just like parents and child decide at home, like today's 2 years, let's stop our meds. No. But we will do a trial week. And so what we do is we work them down very slowly on their doses. We do not just stop ever, but we would take it down by a portion and be like, okay, so we're going to try this instead of taking, 50 milligrams of this medication twice a day, we might go down to 40 milligrams twice a day. So it's a slow wean to make sure that we don't accidentally see breakthrough seizure activity. So they don't actually have to be in the hospital for that, but this is where education comes in, where we tell the parents or caregivers, like, okay, now with this, as soon as you start seeing any sort of this child's seizure activity, and again, now we know that can look very different depending on what kind of seizures they have, then you have to come back and talk to us, because we weren't ready to wean, we'll have to go back to our regularly scheduled dose, whatever was keeping us maintained. And they would also want to communicate, like if the child is going to school, preschool, daycare, anything like that, that we are on a wean, and so that everyone that's involved in that child's day-to-day care would be on the lookout. Did that answer your question? It was a very good question. Okay, so again, we do have our seizure precautions here that we kind of talked about some of these. The other thing is, like, if your child is the child experiencing seizures, they don't ever really need to be locked in the bathroom by themselves. I know, especially if it's an adolescent, they want privacy. Yes, they can close the door. We still need to be able to get to them in an emergency. So that means in the hospital too. They need to let us know if they're going to be going into the bathroom to shower. Because having seizures doesn't preclude you doing your things, right? But we have to still be safe about it. So we do want to make sure that they still are checking in with us if they're inpatient for some reason, or that they have a safety plan at home. The other thing is, for some of these, they might need to wear protective gear, like the atonic seizures that lose that muscle control. They might be the ones that need to wear a helmet. Or they might need to have some padding on their elbows and knees. Sometimes you'll see kids out with their little bike pads, but they're using them all the time. And if they should be wearing a medical alert bracelet or necklace that lets people know that they do have an epileptic disorder and what to do, like who to call in case of emergency, in case they are out somewhere. Especially for those kids who are more independent, like an adolescent who might be out at like a football game without caregivers. Yes.
Back in, when we were in elementary school, there's a girl in our class with epilepsy, and her mom came in and she like did an in-service with school nurse to our entire second grade class.
Oh, that's cool.
What to do if her daughter had a seizure.
Who had epilepsy, and the mom of the classmate, along with the school nurse, came in and did a little in-service telling all the kids in her grade about what she had and the symptoms and how to be on the lookout, be a good friend basically, and that she had a buddy assigned to her every week that would just kind of be her watcher buddy. And now we have therapy dogs. There are some therapy dogs that are trained to know when seizures are about to occur and to stay with their person or to notify, grab someone out and about. There's all sorts of things. And some of these kids, especially with the more generalized, y'all might have heard about auras, where they might see like a vision change that might be like everything takes on a red tinge, for example, or they might hear something that it's not really there, but it's their brain creating this. So they might smell something, like auras can come in different senses, but that lets them know that they are close to having a seizure. And so sometimes they'll, get themselves to a safe spot, or they'll tell someone around them, like, I'm about to have a seizure, this is what's gonna happen. Those people who suffer for them more long-term will a lot of times have those kind of things already in their mind. And there are some things, like when I said a lot of support and education, there are some things we know that tend to set off epileptic events. So lack of sleep, if they're sick, if they're stressed, if their blood sugar is low because they're not taking care of themselves because they're not feeding themselves well, a good balanced diet, those sorts of things are more likely to trigger an epileptic, more seizure activity. So that's part of our teaching with them, like you have to get your sleep every night. You have to find a way to moderate your stress. I know that's laughable, but especially in the nursing school student role. But, those are things like their wellness and maintenance of their wellness. Like they should have their immunizations. They make sure, obviously, wash their hands well, especially in cold and flu season, because any of those little extra stressors on their body are more likely to make them experience more seizure activity. Okay, so we'll talk about febrile seizures real quick, and then we'll do our little Google case study. So febrile seizures are actually the most common type of seizure activity in childhood. This is not epilepsy. These are triggered. These are not unprovoked. So what happens is we usually see these in our younger kids. Peak age is between 12 and 18 months, but you can see them in, really you can see them in anybody, but our younger kids tend to escalate their fevers more quickly. Viruses tend to make your fever run up more quickly than bacterial infections, and so this is when your fever reaches a high number quickly. It's not ultimately that, you know, anyhow. When your fever escalates very quickly, we are more at risk. Also, for some reason, we do tend to see them more in boys, and if there's a family history, we really don't know why that is yet. It implies there might be a genetic component, but again, that's not confirmed. So they are very scary, because usually these kids have no previous seizure activity, and then they're sick, and they fall out having a seizure, and their caregiver's like, oh my good Lord in heaven, my child has had a seizure. And that's scary, but they have a very good prognosis. So really what we need to do when we bring them in and are they are brought in and we determine it was a febrile seizure is we need to treat and support what led to the fever. So if that's a virus, obviously, that's usually more supportive care. If it's bacterial, then we can administer antibiotics. But we also need to talk about like fever management techniques. And we'll touch on some of these with meningitis as well, but we might as well, we can do some here. So things like making sure temperature-wise, like in the room, that we're not adding to the fever by, you know, when you have a fever, you want your warmest, fuzziest pajamas and your biggest, fluffiest blankets, and you're cold even though it's not cold. But we have to be very moderate in that. So while they might want to be covered up or cozy, we can't just like pile all the things on them. That actually contributes to how high their fever can get. Also things like, you know, a cool cloth on the temple or at the pulse points. You know, if it gets really high, of course we could put them in tepid bath water. That's wildly uncomfortable if you have a fever. And I don't mean, it's like room temperature, like if you were swimming in summer or something like that. But when you're already febrile, that's really not a comfortable thing to do. So it's not super, super recommended anymore, but I guess if you're getting desperate. But also our, you know, we can do medication management. So we can administer antipyretics like Tylenol or Advil, depending on the age. When can we give Advil?
6.
After 6 months, yep. And we can use that like regularly scheduled as we see the fever getting high. Yes.
Do we put these kids on a 1-to-1 or?
On a 1-to-1.
Yeah, like if we're.
For febrile seizures, we usually actually don't keep them inpatient at all. Like if they're brought into the ER, we'll make sure, like we would still do our glucose and electrolyte testing and you know, draw some labs, some cultures, make sure what are we looking at here, but then we do the education and they can support them care. Did I guess?
So if a child has a, like, say they have a temperature and they have a febrile seizure, are they more at risk to have, like, recurring, like if they do have recurring temperature? Is it seizure?
Yeah,
activity gonna
if they
be-
have a personal history of it, yeah, that's a really good question. So she was saying, like, if they have one febrile seizure, are they more at risk of having another one later if they have another fever? Yes. If we already know they are prone to febrile seizures, again, so this sort of teaching needs to be kind of presented in the fact that anytime you start seeing your fever run up quickly or getting high, we need to do fever management. Running a fever is good. For a certain amount of time, right? That's your body's normal response to infection, and it is there for a reason. But again, if it's escalating very quickly, and we're like, oh, we were, you know, 30 minutes ago we were 99, and now we're 102. Okay, that's fast. Or if we're getting high, if we're getting into the 103s, 104s, things like that. Younger kids can run a really high temperature and maintain and still be running around, and you're like, you know, adults usually once we hit 101, we're like, I'm dead. Leave me alone. It hits different, okay? But we do want to make sure that they know that going forward as well. That's a good question. Okay, so we can give Rexuldiazepam if we really needed to like break the febrile seizure activity. Literally never seen this given. I felt like I needed to say it because your book said it, so theoretically we could give it. It's just usually not needed, because usually that febrile seizure activity is kind of short and localized to one point in time. So brensodiazepam is really more something we would give in status epilepticus to break that seizure activity, but I guess like in theory, if it was bad enough, in theory. But we do have to require a good history and physical. We wanna know how long they've been sick, what their symptoms were, all of those components, because we wanna make sure that we are treating this appropriately, right? And again, that parental education, that this is now fever management and supportive care based on what's causing the fever, but then also knowing going forward that now they know what it is, now you know it's not necessarily a medical emergency, but you do still have to keep your child safe. Okay, so what I want you to do, I sent you a link